Prostate cancer is the second most common cancer in the world. It arises due to uncontrolled, abnormal cell growth in the prostate, eventually forming a malignant tumor. The majority of low-grade prostate cancer patients live for years without symptoms and without it being life-threatening. However, high-grade prostate cancer progresses quickly and is often fatal. Prostate cancer mainly affects men of African heritage, men with a family history of breast and prostate cancers, and men who are above 50. It's an age-dependent disease, meaning the risk of developing it increases with age, with 63% of cases diagnosed in men over 65 years of age. According to the Australian Cancer Research Foundation, the risk of developing prostate cancer at the age of 85 is 1 in 5. In order for cancer cells to survive, they must avoid and overcome programs that negatively regulate cell proliferation. By gaining the ability to overcome growth suppressors, tumors develop one of the hallmarks of cancer. A prototypical tumor suppressor is retinoblastoma protein, or RB. RB has the power of deciding whether cells proliferate, go into senescence, or apoptose, and therefore acts as a powerful growth suppressor. RB receives signals from extracellular and intracellular sources and decides whether a cell should or should not proceed to the next step of the cell cycle. It acts as a G1 checkpoint by complexing with the transcription factor E2F and determining whether the transcription of genes, and thus the cell, should progress into the S phase. E2F activity is inhibited by RB binding, but it dissociates in response to phosphorylation of RB by CDK4 or 6, allowing transcription of those genes involved in cell cycle progression. RB loss or hyperphosphorylation is common in prostate cancer, meaning there's uninhibited activity of E2F to transcribe genes, enabling cancer cells to undergo further growth and proliferation. To target the loss of RB protein or hyperphosphorylation, which leads to its inability to complex with E2F and thus prevent transcription of genes, we propose the creation of a structural RB analog. This analog would have a higher affinity than RB for E2F, meaning it would bind securely to it. Furthermore, the phosphorylation sites where CDK4 and 6 normally act on RB would be eliminated in the analog, meaning there would be no stimulus for RB to dissociate from E2F. Together, these modifications to create an RB analog would result in continuous binding to E2F to prevent the progression of cancer cells into the cell cycle and thus suppress their growth. A viable drug delivery system is essential for both the efficacy of a treatment and the quality of life experienced by the patient during treatment. With the development of our RB analog, we have also developed a localized administration process in which the drug can directly target the prostate cancer itself. To achieve this, we have adapted a version of a current prostate cancer treatment known as brachytherapy. Our modified procedure involves the injection of a biodegradable matrix gel that acts as a parenteral controlled drug delivery system directly into the tumorous tissue. One of the many advantages of this slow-release system is that patients undergoing treatment would only need a small takeaway dosage appointment once every several months, allowing them to continue their day-to-day lives. As prostate cancer is an extremely prevalent cancer amongst older men, it requires a delicate treatment process as many patients are frail and struggle to recover from heavy systematic drugs or surgery. Our proposed therapy, combined with relatively easy and realistic treatment options, minimizes side effects and disruptions to patients' day-to-day lives while still producing effective results. Therefore, by funding Proscrate, you are not only investing in the future of cancer medicine, but also in the lives of millions of people around the world.